So just let me just tell you a tiny bit about myself and a tiny bit about Arthritis Research UK. And you'll see from the top that Arthritis Research UK is now a merged charity with Arthritis Care. So Arthritis Research UK, some of you may know us, some of you may not, I don't know, but we're actually an 80-year-old charity. We've been going a long time, and our heritage at Arthritis Research UK was very much as a medical research charity, funding 20 to 30 million pounds worth of research each year into both understanding musculoskeletal conditions, understanding what they are, understanding how they arise, and trying to come up with cures for musculoskeletal conditions, including arthritis, and I'll be saying more about what those are. But then increasingly in recent years, thinking about what we can do for people living with arthritis and musculoskeletal conditions right now. And we merged in November of last year with Arthritis Care, which was a smaller organisation which historically had focused on providing support and advice for people with arthritis and musculoskeletal conditions, and we have merged to become a single, stronger charity to have bigger impact. My own role is that I part-time work at Arthritis Research UK, and part-time I work at Imperial College as a rheumatologist, so I see people with arthritis every day. Well, every day when I'm at the hospital, that's my job there. But in Arthritis Research UK, I work on public health and public policy. So today, I'm going to talk a bit about the relationship between musculoskeletal conditions and arthritis. Emma, great. Thank you for sharing that. That's really, really helpful. It's really great to know who people are. So please keep those coming. So we're going to talk about the links between musculoskeletal health and physical activity. So let me see if I can do this. So I want to share a bit about my own journey, and that's the first thing to say. So I always feel a tiny bit of a fraud saying anything about physical activity because I was one of those kids at school that hated all forms of exercise and sport. I was a full-on exercise dodger. My first memory of being in a pool is sitting by the side of the pool screaming that I was terrified of water, and the pool instructor thought that the best way to get me in the water was either to throw me in or to ladle water over my head, and this just never really worked. So actually my dad taught me to swim on a holiday. I think I must have been 9 or 10, and then I swam a bit at school, but I was not a competitive swimmer, and I really hated exercise generally, so I didn't really do any exercise until my 30s, when I started cycling just to get around town. Anyway, about 3 years ago, a friend of mine said, I'm going swimming, why don't I just come pick you up? We'll go to the pool. And so that was 3 years ago, and since then I've become, I would say, an obsessive swimmer, but swimming has really become part of my life. So the culmination was this summer, for me anyway, when I went open water swimming for the first time, and I went with a company. This is not an advert for SwimTrek, but I went with a company called SwimTrek, and we did swimming mainly around islands. It was pretty choppy. There were some high winds, as you can see from the waves. That's me in the middle there. I can't do crawl, although somebody did teach me on the trek, so I was swimming several miles a day breaststroke, but keeping up with the crawlers, so that was good. So actually, I'm really converted to the joys of swimming, and I will tell anybody that will listen for long enough. So let's talk about musculoskeletal conditions. Enough about me, more about musculoskeletal conditions. And people can get quite lost in arthritis and musculoskeletal conditions because there's a lot, because there's so many different sorts, and it's confusing. So Arthritis Research UK, we often talk about there being 3 broad groups of musculoskeletal conditions. We talk about group 1 conditions, which are inflammatory conditions. And these are where the immune system, which is supposed to protect us from infections, bugs, the immune system turns upon ourselves and starts attacking our tissues, our joints. It can also attack skin. It can attack internal organs like heart, lung, kidneys, liver. It can attack anything. The most common of these conditions is rheumatoid arthritis, but others include ankylosing spondylitis, psoriatic arthritis, where people have the skin psoriasis usually, but then it's attacking inside the joints in the same way it's attacking the skin. And the analogy I sometimes use is to type 1 diabetes. In other words, the number affected are relatively small, but it can attack at any time of life. And when it attacks, it's pretty severe. It's drastic. It's going to need lifelong, permanent medical treatment. The drugs we use are quite intensive, has a major impact and needs specialist input. And the majority of the work I do in hospital is seeing people with these inflammatory conditions. And the individual costs are enormous. And some of the drugs we're spending in the NHS to treat these conditions are coming up billion a year for the total budget. It's about 700 million a year now, and that's growing year on year. That's the group one, the inflammatory conditions. The second group of conditions are the conditions of musculoskeletal pain. And these are, for example, osteoarthritis, back pain, neck pain, limb conditions, upper limb pain, lower limb pain, conditions like fibromyalgia where people are in permanent pain, even though the joints themselves can be sometimes healthy in fibromyalgia. So these are the conditions of musculoskeletal pain. And like type 2 diabetes, these affect enormous numbers of people. This is over 10 million people in the UK. Like type 2 diabetes is strongly lifestyle related, so physical inactivity, muscle weakness, obesity are strong risk factors. And like type 2 diabetes, the majority of the care for people with these conditions is based around self-management, people looking after themselves, people taking control of their own health, but a small number with the support of their general practitioner, the support of physiotherapists perhaps and other professionals. And then at some point, some people, so osteoarthritis, for example, about 1 in 4 people with osteoarthritis of the hip or knee will go on to have a joint replacement, but the majority won't. The importance for the country, the sort of public health importance of these is just that the numbers are absolutely huge. Oops. And then the group 3 then, that was the third group of conditions. This is osteoporosis, fragility fractures. And osteoporosis is a lot, people do get very confused, health professionals sometimes get confused as well. Osteoporosis is a silent, painless condition. It doesn't cause any problems in and of itself until a bone fractures, and that can be a long bone like an arm or a leg bone, or it can be a bone in the spine that sometimes can just fracture. You bend down to pick something up off the floor, and the pressure of bending over will cause the vertebra, the bone in the spine, just to crush. And the analogy, if you like analogies, this may be helpful. If you don't like analogies, ignore it. But is high blood pressure, hypertension. That it's a silent risk factor, and you'd never know you had it. You'd never know you had osteoporosis until you break something, or if somebody looks. Well, you'd never know you had high blood pressure until somebody goes and looks for it. But then disaster strikes, and the disaster, which in osteoporosis might be a hip fracture or vertebral fractures, which are extremely painful and sometimes don't heal and lead to changes in posture. The disasters are expensive and difficult to treat and often need hospital and specialist treatment. So it's okay if we can prevent more fractures in the first place by treating the risk factor, treating the osteoporosis. Again, it's like hypertension. If we treat more people's blood pressure, we'll have to worry about less heart attacks and strokes. I am going to stop for a moment. That's what I'm going to say about the conditions themselves. Let's just have a moment and see if any questions, either speaking questions or typing questions in. I'm going to press on, but shout up or type something in if there are questions. Okay, so what is the impact of these conditions? So first thing to say is the impact is enormous, that these are the top cause, musculoskeletal conditions together, those 3 groups are the top cause of pain and disability in the UK. So when we talk about disability, we often don't think about arthritis as a disability, but of course it is, and it's the leading cause. And there's lots of statistics here. I'm not going to go into all the statistics, and all these are available in Arthritis Research UK publications. I see I've forgotten to put the reference on here. But if people can email me, we can share emails, and I'm happy to email the presentation around as well, and I can add the reference on. So the loss of quality of life is enormous for people affected. You've got 3/4 there, 78% of people having pain most days. People, 2 in 5 people, 41%, can't stand up for long periods if they have arthritis. That's going to affect your ability to walk, affect your ability to travel, affect your ability to interact with family, to play with children or grandchildren, to play with your friends if you're a child with arthritis. Depression is very common for people in pain, and we know there's a complex and reciprocal relationship. So if you have depression, you are more likely to develop a painful condition, because pain and depression are intimately linked. It's not surprising if we think about how involved the brain is in feeling pain. And of course, if you have pain, you are more likely to become depressed. So there is a vicious cycle there. Osteoarthritis, that affects just under 9 million people in the United Kingdom, and that's responsible for about 200,000 joint replacements a year, about half hip, half knee. 300,000 fragility fractures in the UK each year. of which 3 million people having the risk factor of the osteoporosis. And the direct cost beyond the individual, we start thinking then about the cost to the economy of all these joint replacements and the healthcare costs. So it's in terms of program budgets, it's about 5 billion and then about another 10.2 billion of costs. We say about 1 in 4 of the population sees their GP about a musculoskeletal problem each year. It's absolutely enormous. And then I have done something there. What have I done? Oops, there you go. And then why is this then a public health problem? Why should those of us who are interested in public health be interested? Well, first of all, there is a strong relationship with deprivation, and that is of big interest to public health. That the more deprived you are, this is looking at joint pain and back pain, the younger you are likely to start getting your pain, and the more likely you are to get pain at every age. So coming from a deprived world, low education attainment, deprivation leads to more back pain, more joint pain, and of course they're people most often that are going to struggle to access the services they need to look after their health, not just health services or other care services, but also leisure services and so on. We'll get on to leisure very shortly. There are big implications for work, which is a public health interest. As well, that we know that good work is good for your health, and if you have a musculoskeletal condition, you're more likely to be out of work and you are going to retire earlier because, for example, if you're unable to stand for long periods, that's going to make a lot of jobs harder. And if you think about people who have more deprivation are more likely to be in manual jobs and jobs that require a lot of lifting, standing, and so on, so are going to experience even more. There's a sort of double whammy there. And employment is a big interest to the country and the economy and to employers as well because of the huge amount of working days lost, both in public services, local authorities, in health services. That's a big interest to the taxpayer because we are paying for those services, but also more widely. So there's economic impacts on the individual, on employers, and on wider society. So this is Richard Dole, who was the man who proved the link between smoking and lung cancer. And smoking and lung cancer is a real public health success in this story. We've just seen that smoking rates are down to 15% now in this country, which is one of the world's lowest rates. But it's still fascinating to me that that's 6 or 7%. That's 7% of these. That's 1 in 7 people. In the country still smokes, 15%, 1 in 7. So that's 65 years after we proved the link between lung cancer. We've still got 1 in 7 people smoking. And that's important to remember how hard it is to change behaviors. And smoking is something which is clearly bad for you. There's no upside. It's not like obesity where you do have to eat food. Something that's clearly bad for you, 1 in 7 still smoke. Richard Dole used to talk about wanting to die young, as old as possible, which I think is a fantastic phrase. Lifespan is getting longer and longer. We're living longer and longer, but the health span, the period of our life for which we are healthy, is also increasing, but is not increasing at the same rate. So we've got a growing period of towards the end of life when we have poor health. And people like DeFries and others have talked about square wave deterioration. What we want to do is be really, really healthy until we're 85, 90, or whatever it is, and then fall off our perch very quickly. So what this is leading to, this increased period of ill health, is that health and care services are having to think more and more about how we support people to stay well throughout our whole lives so that our health span can grow too. And public health can no longer only look at mortality, it has to look at morbidity as well, that ill health. So I'm just going to stop for another moment. That's sort of the public health reasons why we need to take a sort of wider perspective about arthritis and musculoskeletal conditions. It can't just be about more physiotherapists or more GPs or more rheumatologists, come to say that. I'm either making perfect sense or everybody's fallen into a coma. Hopefully not. So conditions of musculoskeletal pain. So why do we need an alternative model? And this is where we're heading towards our physical activity. So we need another model because I'm not going to talk so much about osteoporosis today. I'll say a little bit about the inflammatory conditions. That's the group 1 conditions where the immune system is attacking the body. But that massive group, that group 2, conditions of musculoskeletal pain, actually medicine has very little to offer. So the drugs aren't very good. They're limited what we have. They don't work very well. They're quite toxic. They have lots and lots of interactions with other drugs and also worsen other things. So you've got painkillers that worsen problems with people's bowel, and you've got anti-inflammatories that cause problems with kidneys or breathing, and if you're on this drug you can't have this painkiller. So there are a lot of interactions for a group of people with arthritis that often have other conditions. So if you've got for example, if you've got cardiovascular disease or type 2 diabetes, there's a sort of 2 in 5 chance you also have arthritis. So people tend to have multiple things. And also, the more we prescribe and the more we send people to GPs and people like me, we're just promoting medicalization. What we're doing is we're disempowering people from looking after their own health. So a few years ago, Arthritis Research UK published this report. This was a piece of work I supported about a public health approach to musculoskeletal health. And what we wanted to do was shift the focus from just treating musculoskeletal disease when it happened to promoting musculoskeletal health lifelong. So in other words, not waiting until your joint was so bad it needed an injection or needed a joint replacement, but promoting lifelong health at every stage of life, from pregnancy through to infancy, childhood, early adult life, late adult life, and so on. A lot of this is about physical activity and healthy weight. And the idea is that this circle in the middle, that musculoskeletal health has lots of components. You need strong muscles, you need coordination and balance, you need a stable spine and stable joints so you don't get injuries, but joints and spine also have to be supple. So we've got strong and flexible. You've got to be both. Your bones have to be sturdy, so when you have a small fall, you don't break things. And all this has to happen in the context of no pain, no stiffness, no fatigue, and good mental health. It's quite a big ask. But once you start framing things as not about treating and preventing individual diseases, but actually building those 5 components throughout your life at every stage, what we can say is that it doesn't matter who you are or whether or not you have pain, whether or not you're at risk of pain, whether or not you recently had an episode of back pain and are worried it will come back. At every stage there is something we can all do to improve and maintain our musculoskeletal health. And it shouldn't have been a big paradigm shift, but it sort of was. It was quite a surprise to the public health world. John Newton at Public Health England gave a lecture a couple of years ago, and he said in the history of public health, or his career in public health, he could remember no other time when people were coming to him from outside public health and saying, you've got to make our condition a public health problem. Normally it's the other way. Normally it's public health saying to diabetes or cardiology, you've got to think about your disease in a public health way. So this was unusual. But of course, musculoskeletal health conditions are amenable to a public health approach. The benefits for all 3 groups, everything inflammatory and degenerative, that's the group 2, but also for osteoporosis, the benefits are well established that for almost any musculoskeletal condition you will benefit from physical activity. The risk factors are shared with other long-term conditions like obesity and physical inactivity, and we've got some proven interventions to deal with this. So we then, Arthritis Research UK, worked with the Department of Health, which is now the Department of Health and Social Care, Public Health England and NHS England to produce this report, which we published last March. And it was a real piece of engagement with those organisations to get all those logos on. In fact, just getting the logos on was several conversations with everybody's branding teams, and those of you who've done that will know how much fun that is. But actually this culminated, this was 2 years working with those groups and a lot of people of academics, of people with arthritis, of professionals, of other interest groups, thinking, what does physical activity provision look like for people with musculoskeletal conditions? And what we know is that appropriate activity improves health. We wanted to make the point, and I'll talk more about this, that if you have weak muscles and you start exercising, your pain will get worse, not better, and you're likely to injure yourself. So particularly for people with musculoskeletal conditions, it's a priority to build strength and stability first, and then start to work on building duration and other factors. And we'll talk a bit more about the approach, and that's what the report is based on. We also have to recognize that pain is a huge barrier to physical activity participation. So there's no use just telling people to exercise who are in pain if we don't also explain to people that we understand their pain and we can work with them to find ways of helping them manage their pain and reduce their pain. And in the fairly short, well, the short to medium term, they will start to experience an improvement in pain, though sometimes it can take 6 to 18 months. It depends on the condition. So they may not see rapid improvement. And the final principle in this was we neither can nor want to provide everybody with physiotherapy. It would not be a goal that everybody with a musculoskeletal condition should have physiotherapy. That would be very disempowering. And it would not be a goal that everybody should have physiotherapy to improve their musculoskeletal health. We want people to be able to do it themselves. So we came up with this tiered, this tiered approach, and I'm going to talk through each of the tiers. And this is not about individuals. It's not about saying individuals, we should test individuals and work out where they go. It's about trying to understand what local authorities, what health communities, what the wider public health system, which includes the leisure sector, should make available. We need to recognize the whole thing needs to be underpinned by support for behavior change. That if practitioners, and by that I mean the wider public health workforce, whether that's that's a doctor or a nurse or a physiotherapist, whether that's the receptionist working in a leisure centre, about how they speak to people and approach them, when they handle queries about membership. It's about you also think about people that work in libraries or hairdressers. How do we support behaviour change? How do we talk to people about their pain? How do we talk to people about physical activity? And lots of work going on at Public Health England and the Royal Society of Public Health about that. None of this then is to replace the medical interventions. Medical interventions can carry on alongside this. I'm going to talk through the tiers. Tier 1, this is self-directed accessible community facilities. You'll be pleased to see swimming pools are there, and they need to be accessible. What do we mean by accessible? Well, it partly means they've got to be within geographic reach. They've got to be affordable. But also, we talked about promotional materials reflecting people with arthritis. So something we all hear from people is, well, I don't feel I can go to the pool, I'm too fat, or I look too disabled, or I don't, it's full of younger people. Now, I swim in a pool, and I know that is not the case, certainly not where I swim. But that is people's worry, people who are not familiar with the gym. The environment needs to be manageable and safe if you're afraid of falling. Are there grab rails where you need grab rails? Are there non-stick surfaces where you need non-slip surfaces? I'm talking in pool terms because of the pool environment, but this could apply anywhere. It could apply to a park. If you're encouraging people to to walk more in the park, it could apply to lots of other environments too, to active transport as well. Manageable and safe, something a lot of people that I see in clinic will say when we talk about swimming is they can't get in and out of the pool because there's no steps, only a ladder. And if you've got arthritis in the hips, knees and or shoulders, you won't be able to get in and out of a pool on a ladder. Now, some pools still have steps, but not that many. And actually being sort of in and out on the big seat thing is not appealing to a lot of people. So the environment has to work for people, and we haven't always built environments that feel and look supportive. And staff have to be informed and supportive as well. So again, a lot of people will have gone to a leisure centre of some sort or another environment. So I'm not bashing leisure centres, and some do this amazingly well. Many do. But sometimes people say, I want to exercise, and the staff will say, you better, have you got any problems? Well, you need to see your GP to talk about that. And that often puts people off. People will never go back. Or people say, I'm having trouble. Is there somebody you can go and talk to if your stroke is making your shoulder pain worse, or your back pain worse? Is there somebody you can talk to if you're getting knee pain when you're using a piece of equipment in the gym? Who do you talk to about that? Who can you go to at the gym and say, my back's been bad the last couple of weeks. Does anybody know some exercises I could do? And do people know that that sort of advice is available? So that's really important. So accessible community facilities sounds a bit passive, but it's not. It's a really active process. And I know Swim England has done work on dementia-friendly swimming, and so it's a really interesting question to think, what would arthritis-friendly swimming look like? What would an arthritis-friendly environment look like? Who would this suit? People that have been active, enjoy physical activity. If you're like me until 5 years ago and you're an exercise dodger, or have been, I'm pleased I'm not. But if you were, no, you're going to struggle to manage this if you've not swum before, and if you've never liked swimming. And also, if you've got bad symptoms that mean every time you go swimming you end up with terrible neck pain for 2 weeks, this isn't going. You're going to struggle with this, which takes us on to Tier 2. So Tier 2 is supervised physical activity. So this could be aqua, it could be a dance club, it could be Tai Chi, walking clubs, lots and lots of different things. You just put a sample there. And this is sometimes fitness professionals leading, depends on the activity, and it's sometimes a trained peer that can learn to deliver this. And these are what characterizes these sorts of groups is they're not a program. It's the Tai Chi runs every week. You can, or twice a week, you can come, you can not come. You can do part of the session. If you don't feel up to it, you can just do 20 minutes. If there are a couple of exercises you don't do, you just sit them out, and it's not individualized. It's what the group is doing. What we need is a range of activities to suit the population. Some people don't like getting wet. Some people don't like not getting wet. Some people find the water supports their weight and it's great. Staff need to know a bit about musculoskeletal conditions. So sometimes people will come and say, I tried yoga, but I'd like to do yoga, but I'm worried about sitting on the floor because I'm worried I won't be able to get up. My legs aren't strong enough. Now, a good yoga instructor will say, oh, well, here's some things you can do in the chair. Here are some other ways of doing it. Don't worry. Or we'll just put your hand up when you want to, and I'll come and help you up. But that requires a staff with a bit of understanding. And this is for people that enjoy groups. We need to bear in mind some people hate groups, some people enjoy groups. If you hate groups, this is not going to be for you. But if you enjoy groups, this is going to be great. And groups can be great for people who are socially isolated and want to meet new friends. It can also be great for people who just lack the confidence or the self-efficacy, so they need the discipline of, well, this is the day I go to my group, or they're just nervous about exercising on their own. It's not something they've done. They might be new to exercise. They're worried about falling. Well, doing an aqua class or Tai Chi, you're surrounded by people who could help you out. Okay, so the next tier is now we're getting into structured rehabilitation programs. I've mentioned one there, Escape Pain. I've got a slide coming up on that, and there's another one. Escape Pain is a program for hips and knees in particular, and these are defined programs. So Escape Pain is a 6-week program, and it's unlike, say, a Tai Chi group or yoga. You can't dip in and dip out. It's 6 weeks. You have to come to every session. You can't miss a couple early on and come to a couple later on. You can't dip in and out. You've got to register and enroll in the program. That could be a self-referral. It could be a referral from a professional. But there are clear pathways of how you get there. And instructors, which can be fitness professionals, can be physiotherapists. Somebody actually has done some work on seeing if you can train peers up to do this, but it's a very highly trained activity that requires following a very strict protocol. So who are these sorts of programs good for? Well, they're good for people who have quite bad symptoms, who've got a lot of deconditioning, their muscles are weak, and they might be for people who've tried exercising before, but their symptoms just got worse. So they joined a walking club, but they just found their knee pain got worse and worse. Well, it will do because they haven't built up the muscle strength first to enable them to then participate in walking. So you've got to have this sort of supervised rehabilitation approach. It's very good for people who are very fearful of exercise because they've tried it before and it went badly. They got worse, or they felt unable to keep up. So this can be particularly good. The final tier then is the one we're most familiar with in some ways, and we were very deliberate. This is the last tier. Not that physiotherapy or exercise sports and exercise medicine is a last resort, but sometimes we just do use it as a first resort because someone has a problem. We just refer to physio because we don't know what else to refer to. And so I think we're all guilty of this, and we don't have the time, and I'll say a bit more about this, but we don't have the time and energy to have proper conversations about physical activity. So this is going to be good for people with rare conditions, very complex conditions, very severe conditions, or people with significant comorbidities, very bad fear avoidance, very depression, anxiety, that really need somebody highly, highly trained and targeted, prescribed exercises to get their joints better. So that's the pyramid. It's people vary over time. The aim is always to get people into the lowest tier they need. So if someone is currently having individualized support, the hope is that after that period, and I'll mention a program in a few slides' time about helping people transition from individualized support to more general activity. The aim is that after physio or after something like a rehabilitation program, you're then signposting somebody to either supportive physical activity, what would they like, what would interest them, what's suitable for them, what's accessible, or if people prefer, or if they're ready, for people to access things on their own. Of course, people can be using more than one tier at once, and people can be moving between them according to the need they have. So they may be having physio on their shoulder, but swimming twice a week. So it's not, the point is this is about the provision that should be available locally, not about permissions and restricting access. It's about growing availability. So I will take a pause for a moment again before we go on to talk about some specific programs, just to see if anybody has any questions. That was an accidental slide. So escape pain I've mentioned a little bit about, but this is the 6-week rehabilitation program. The benefits are sustained for 2.5 years after taking part in an escape pain program, and people get a roughly 30% reduction in pain and a 30% improvement in function, as well as the improvements in mental health and well-being, and an estimated cost to the health economy as well. People aren't using drugs, they're not going back to their GP, they're not needing individualized therapy, and there's some evidence it may reduce your need for hip and knee replacement as well. So it's 10 to 12 sessions over 6 weeks. And it's very personalized within that. So the instructors are highly trained, and it's not just a self-management group, it's really focusing on exercise to strengthen the joints and reduce the pain, and it's effective. Another program is yoga for low backs. The website is there, and a couple of the academic papers cited there as well. This is not just doing some yoga. Again, this is a 12-week class over, so it's a class a week over 12 weeks. It's a more expensive program. It costs about £300 per person. Escape pain is cheaper. Now, that might be paid for by a local authority. It might not. Or local authority might make a contribution. You might still have to pay something. And that's slightly in England, it's a bit different in Scotland and Wales, but in England there's this sort of things provided by the NHS are generally totally free, whereas things provided by local authority people usually have to make a contribution to. But again, this is a structured program for again, that tier 3 and this one's particularly beneficial for low backs. And we just know that the huge problems people with low back pain have. And again, we've got a 30% improvement here. It's that number again, but a significant reduction in work absence from low back pain. So you'd think that the country would be frantically trying to provide this for all the people that need it, but sad to say, not yet. So some other interesting things going on. I like talking about interesting things that are going on, and actually if anybody has great examples of water-based stuff that's going on, I'm more than happy to add them to the slide deck. This is there are many, many different slide decks that I cut and paste, and there's some unique slides each time, but some of the ones on interventions I love to be able to share because I think it's inspiring about what others are doing, and sometimes we just don't know. Sheffield, I think, is doing some really interesting stuff here using the website is there, the Sheffield Persistent Pain website. There's a YouTube video I've quoted there, but they've got some great resources here, and this is ShipShape, the provider, and it was the NHS and the council. So real partnership working here, and this is health trainers. This is a few 1-hour one-to-one sessions to encourage and support people to become more active. So it's that behavior change piece. But what was really interesting here was that they gave the health trainers specific information about chronic pain. So you're not getting, people are very anxious about chronic pain, professionals as well. People worry about how to advise people in pain to exercise or to make lifestyle changes. So it was giving a small amount of training, and there's an academic paper at the bottom there, Harris, very readable paper actually, using health trainers to promote self-management of chronic pain. And then also in Greenwich in South London, they've done some work as well, again, trying to support people to make behavior change. So sometimes we just spend lots of time investing in the interventions, but we don't invest in how to support people to change. There is actually some new data for this slide, and I need to update it, but this is in Rotherham, so you've got the partners there involved at the project at the bottom. But this was, how do you take people that have had some physiotherapy for an acute problem, tier 4, how do you get people to become exercisers? So how do you help people transition? And so what they did is this step 1, step 2, step 2, step 3. So the step 2 was the new bit, so people that had had some rehabilitation were then offered to take part in a program helping them learn to be independent exercisers. And in the first 12 months, they had just over 300 referrals for back pain. Nearly half of people that were referred actually went on to do it. And of that, 2/3 went on to become, to maintain activity. It sounds awful because by the time, you know, it's everybody that agreed to be referred in the first place, so that's a chunk. I can't remember what the data is for that. And then half of those never actually bothered, and then another half didn't see to it. But actually, that's still quite a lot. If you think about, you know, the scale of the interventions, the scale of the problem, that's still a lot of people coming through that became exercisers. And there's Stuart standing there having a little stretch, and, you know, doing really, really well. So, and again, will we as a health and care system, which includes the private sector, includes the not-for-profit sector, includes all the sectors, will we work together to help people transition to become physically active to maintain their health? I'm coming into the last section, so I'll stop for another half second also to sip some water. So then, the last part then is, what are health professionals? And I think health professionals, it's not that health professionals are more important or better than any other professionals or any other part of the wider public health workforce, which includes everybody from the chief executive to the cleaner. Why are health professionals important? Well, first of all, I think that people in pain often do end up at a health professional. It's our job to try and demedicalise and support people to make those lifestyle changes, but also because people, if health professionals get things wrong, that has a very lasting impact. So it only takes one health professional to say to a patient that their spine is crumbling, and that patient is never going to exercise ever again. It only takes one health professional to say, well, make sure you can exercise, but make sure it's gentle, and that person will never do the muscle strengthening exercises they actually need to do to reduce their pain. So health professionals, I think, get it wrong all the time, and it's like so many things, we have not had. Well, it's a cop-out. I think health professionals are not very good at this, but the systems have not been geared towards promoting exercise. So how do we tailor the messages? Well, the physical activity benefits infographic there that's pictured at the left side of the slide was developed to communicate the benefits better to clinicians, but actually we put some up in clinic and patients like to see it as well. And we can see that the joint and back pain reduction in 25% of the risk. And it's got the basic advice: be active. So try to be moving. 150 minutes of moderate exercise a week. Moderate means your heart rate goes up. It means you can have a conversation but you can't sing a tune. Now you might say you can never sing a tune anyway. Or 75 minutes of vigorous. That's like panting. That's like you can't actually hold a normal conversation. Sit less, which is physical inactivity, is separately important. So if you're sedentary all day, just exercising in the evening does not undo the inactivity. So you have to move lots during the day. And then building strength and improving balance if people are at risk of falls, which might be because they're older. It might be because they have other conditions, neurological conditions, for example, or musculoskeletal conditions making the risk of fall. And then this project, this moving medicine project, I'll just briefly mention. to consolidate the evidence and produce resources to help clinicians talk about physical activity. We know that you only need to advise 12 people to be physically active if you're a doctor. I mean, I don't know if doctors have magic powers, but people do listen to us sometimes, not very much, but a little bit. So only need to give brief advice 12 times, and somebody will be meeting physical activity levels at 1 year. So that's not a great deal, as opposed to smoking, which is much harder. So we need to make every contact count. So if you're seeing a patient, why are you not mentioning it? The resource they're producing looks a bit like this. I've just seen the draft of it. If anybody on this call would like to see a draft of it, email me. The consultation, I think, officially closed on Monday, but I only sent my feedback yesterday, and I'm sure they'll take more for a day or two. So if anybody feels passionately and would like to comment, just let me know, but they'll probably need it the next day or so. And it's saying that if you have no minutes, here's some things to say. Just mention physical activity, reassure people they won't do any damage, and then signpost people to where they can find out more. If you've got 2 minutes, you can still do a lot. You can talk more about the specific benefits. You can talk more about the concerns people might have. Will it make my pain worse? Can I do any damage to my joints by exercising? And then more minutes is, when you have lots of time. It's a proper consultation. You might be spending 10, 15 minutes. This ties in, this is WHO Physical Activity Plan, which has just been published a week or two ago. And to get people exercising then, we've got to have all these things. We've got to create active societies by changing norms and attitudes. That's public health bread and butter. We've got to have our spaces and places right, our programs and opportunities, and those two together, I think, are our physical activity pyramid. That we've got to think about what's available to people, and then how do we create the programs, and then there's the government and policy enablers. How do we actually support all the sectors that provide support to be supportive? And then this, I think, is my final slide. It is. Which is to say that after 5 years since Arthritis and Swimming UK published that report, really to get Public Health England to take musculoskeletal conditions seriously and really think about that, in 2018, so 5 years on, Public Health England, this was just a month or two ago, announced that musculoskeletal conditions will be one of their priority programs. So it's actually a really exciting time at the moment. Public Health England actually starting to scope what their program will be on musculoskeletal conditions, and physical activity has to be a major part of that. It won't be the only part of it, but it does have to be a major part of it. So there you go. That is me. That is a whistle-stop tour of musculoskeletal conditions and physical activity. I hope that's been interesting and useful. We said about an hour, but we are not limited to an hour. I certainly have more time, but we have time now for questions, discussions, comments, disagreements, challenge. And why don't I now hand back? What I think I need to do is hand back. Maybe they can just take it from me. Don't actually know how to do this. But hand back control. How do I hand back control?
It's all right, Benjamin. I've got it. It's fine.
No problem. Control.
Yeah, super. So, does anybody have any questions for Benjamin, obviously around everything that he's gone through, whether you want to ask some specific questions, or whether you've got any questions about how you may be able to implement some of that stuff into site, feel free to unmute your microphone and speak now. Always love a bit of awkward silence. Anybody got any questions? If you don't want to use the microphone, feel free to pop it in the chat function as well. Obviously, just make sure that you pop it to send to everybody.
Well, can I ask a question to the group and see if I'd be really interested in, does anybody have any good examples? And it might be individual people or individual groups, or it might be at sort of system, sort of a center level or at system level of where this is being done well. Well, so we've got so Lara's saying hoping for some ideas. I think that's. I mean, Laura. I mean, so here's a question: Is this something we should be doing well? I suppose. You know, what might the role be for, particularly thinking for the swimming sector? Is swimming the right word? But you know, for the sector, what should we be doing well? Does any? I mean, my thought. I mean, one thing I think about a lot is access. So one thing people say a lot. I talked about the ladders to get in and out of pools, the slippy floors to get from the changing room. You know, the lack of grab rails in showers, the lack of images that look like people with arthritis. Is access something? Is that feasible to improve some of the access? Is that going to be something that's too difficult? So, Lara, you're asking who should we be meeting with locally? Lara, tell me a bit about where you work. I'm not sure you said anything. What's your role, Lara?
Lara, unmute yourself. Come on, you've done this before.
Come on, I've shared a picture of myself wearing a swim hat and goggles. I mean, you know.
No, Lara.
Well, maybe Lara can't. What I'd say, so Lara's asking who should we be meeting with locally. So I would say, first of all, people with arthritis. So are there any groups, either formally or informally, that meet with people with arthritis? Do you, again, Lara, I don't know if you work at an individual centre or you're sort of working at a larger geography, but within a centre, do centres know from questionnaires joining who the people with arthritis are that are in, and could you approach those people and say, look, we're trying to understand how we make our service better for people with arthritis. Would you be interested in coming to an open meeting to hear about it? Or you could put signs up saying that that's something you're interested in. So meeting with people with arthritis. It could be meeting with local public health teams. So you could go along with copies of the Arthritis Research UK reports on public health, on physical activity, and saying, look, we've looked through these reports and we think there's a real opportunity to link some of this up. We know that Public Health England has got musculoskeletal conditions as a priority. We can see ourselves in lots of what these reports are recommending. Can we have a conversation? It might be worth meeting with local providers of physiotherapy or local orthopedics or rheumatology departments, partly because they're very powerful and do have influence and sometimes budgets. In the world of no budgets, health services still have budgets, about the only bit of the public sector that still does, and saying, what can we be doing to create better signposting between your service and our facilities. So those are some sorts of meetings that could be having, meeting with local authorities, meeting with local councillors, and then sort of nationally thinking organisations like the Royal Society of Public Health who are very interested in this sort of wider public health workforce. How do we get everybody that comes into contact with people to know more about arthritis? So there are just some examples. And come and meet with us, come and meet with Arthritis Research UK, and we'd love, we've been having lots of conversations with Swim England over the last year or two, and I think there's a question, should we be doing a big national piece of work, but maybe some local pieces of work, maybe we need to do some demonstrators. That's some ideas from me. Anybody else by text or voice have any other ideas of people that people should meet with? Okay, hang on. So we've got here. So Lara is having difficulties not speaking, but being heard through the system. Jane also is having difficulties unmuting. So I think we've got some unmuting issues. But Jane, you ran a program at Luton Hydro Health doing this style of program. Could you just type in, sorry you can't hear anything specific. Oh, Laura, I'm seeing lots of good things you wrote here. So Laura then said, no, Emma. So Emma Walker, you were saying, or somebody was saying, we have access to stairs. So that's great. Is that something, I wonder, is that something that we put on, you know, in the materials? Is it on website? So that I've used the, in North London, we've got the Better chair. I'm actually in Manchester today, but I just go to the Better pools, which are just, that's what our local authority provides. And there's very little information that I've seen on the website. You might be there somewhere just about accessibility. It's certainly not something they shout about. So stairs, I think, are brilliant, and hopefully with a rail by the side. And somebody else has said, we are hoping to introduce this into our hydro pool of specific health condition classes, similar to those in other dry side centres, which sounds great as well. I think there's a whole question then as well about oh, and Jane, thank you. Jane sent a YouTube link. I'm going to look forward to seeing that. Jane, what's your role? I don't think you mentioned what your role was. I'd love to know your role. But I'll look forward to looking at that video, and you never know, it might make some screen grabs, might make that into our presentation. Jane's also mentioned having a pool hoist. That's really good for some people. Definitely, and there's a midpoint, isn't there, between people that need to and are willing to use a hoist and people that feel they want to get in and out of themselves, just can't quite manage a ladder. I think there's certainly I've heard from people with arthritis that some people just aren't so into the hoist. It feels a bit like a public dunking to some people, but people are going to have different preferences. And then Luton Hydro Health, you've done the video. And then there was something, yes, we were just saying about having the hydrotherapy type pool. So that's something, people are really interested in people with arthritis. So a couple of things I hear about a lot in water temperature, because people often want to know, what is the water temperature of the pool? And I find that there's 2 or 3 different pools I swim in. They all have their own temperature. And it's just not something which ever is written at poolside or is available on the website. I think part of that's because it's sort of a move to lower temperatures, I think, possibly. I quite like a cold pool, that's just me. But people with arthritis like a warmer pool, and sometimes there's a small children's pool which is warmer that they can do, and if it's not called the children's pool, if it's called the small pool, and it's warmer, could that information go on a website? If people have been doing hydrotherapy exercises, people often say, well, my hydrotherapy has come to an end, but that's, but then what more can we do thinking about the Rotherham program to help people move from individualized hydrotherapy to taking part in a class which is being run in a less specialist way or being able to exercise on their own. So do we have data on how many people transition? Because that would know. Because that's really important data for pools. Like if leisure centres want to increase the number of people that come, actually, if you come to do a specific program, and then that gets you becoming a lifelong exerciser and becoming a member of that leisure centre, that generates income and participation, which is important to leisure centres. I mean, my sense is there's a huge market out there, which is a bit untapped, of people that could be using leisure centres but aren't because people are anxious and afraid. Amanda, so you say, as a swimming teacher with no formal training, I'm worried I might make things worse. And I think that's a really interesting point, isn't it? So where is the brief? So here's a question to Amanda and to others. If there was a program which might be let's say it was some e-learning followed by a half-day hands-on, so you sort of prepare yourself with some knowledge and then come. What demand do we think there might be for swimming teachers to take that up into just some knowledge about the basics of musculoskeletal conditions? It's not something that I know exists, but I wonder if there's a market for that and if that's something people want to do. And I thought from a leisure centre's point of view, it would be really appealing to know that there's at least one teacher or one instructor that's around at least some of the week that can specifically help out. Sometimes I think, some people say, what's a public health, what would a world look like where we had a public health approach to back pain? And I think it's a world where you wake up one day or you're finishing work and think, my back is really quite sore at the moment, and your first instinct is to go not to your GP or to call a physio, but your first instinct is to go to the leisure centre and say, look, my back's a bit sore. Is there somebody here who can help me with some exercises? And they might say, oh, actually, so-and-so is here, but only can come on she's only here on a Thursday. But if you come on a Thursday evening or a Saturday morning, say, actually, yes, she'll be here. Do you want to arrange a meeting with her? And then that person comes in, and there might be a back class at the leisure centre. There might be or some one-on-one support for people that need it. So that's really what we need. And so, Susan, you're also saying that somebody else is saying that there could be some interest as well. So there is some interest. I mean, I think that's a really good question to organisations like Swim England. Is that something that, how many instructors around the country might be interested in something like this? What's the market for instructors, but then what's also understanding what is the market for people with arthritis out there that might be interested in seeing a swimming instructor who knows about arthritis. It might not be about swimming, it might be about lots of forms of exercise. My friend Emma, who I haven't named her till now. So Emma's the woman who, and if anybody missed the beginning, I became a swimmer about 3 years ago, and Emma's the friend and also joined me on the swim round the Greek islands that I did this summer. So Emma has been swimming her whole life. She's Canadian. She grew up with the big outdoors. Emma has quite bad osteoarthritis in her early 40s. She had a knee injury as a child, and so she's got really bad arthritis and is too young to have a knee replacement. And she finds that swimming is one of the things in exercise generally, but being water-based is something that really, really helps her knees. So she has all sorts of exercises she does in the water to strengthen her knee. And so when I'm sort of creeping up and down doing not very fast lengths, she'll often go off and do some of her own physio exercises. So maybe there's a real gap for supporting people with arthritis to exercise and identifying leisure centres that have a good offer for people, so good accessibility, and also part of the offer is having some instructors there that can help people with arthritis. So, good. We're just over an hour, and yes, the dementia-friendly training. So that's right. I'm going to say to Lara, I know a bit. Would everybody on the call know a bit about the dementia-friendly training? Is that something people know about? It might be that everybody on the call would know about that well. I know a little bit about it. Yes, and that's so there's a point here that's being made. So many people, I'll read it out, many people with arthritis find that warm water is vital. Main pools are always too cold, therefore most facilities currently available are not too accessible. So yeah, I think that's a really big issue. I think knowing when those pools are available. Hydro pools are increasingly hard to come by. I think it depends very much on the part of the country. And I think for some people with arthritis, there is an aim, if possible, to get your joints strong enough in a hydro pool so you can then use a regular pool. But if they're too cold, they're too cold. But it would be helpful for people to know what the pool temperature was. And in places, one of the pools I swim in London has 3 different pools within the leisure centre. And I know they're all at different temperatures, but I don't think that's advertised. I don't think it's promoted. But yes, I think it's different things are for different people. Some people with arthritis, it depends how bad people's arthritis is, will only be able to find they can only exercise in hot water or warmer water. Something that a lot of people with arthritis can find really, really helpful is being able, after a swim or an aqua class, being able to sit in a jacuzzi or a steam room or a sauna. Like, again, quite a few patients will say that, part of, they're willing, they'll go and do 10, 20 minutes work in the water, and then afterwards an essential part of that for them is getting somewhere really, really warm afterwards, which helps with their pain, and that's fantastic. Particularly, I think conditions like fibromyalgia, but also back pain and osteoarthritis so being able to get into something really warm is really beneficial. And some pools have those facilities, some don't, but again, advertising it as part of an arthritis package, and saying, after you've swum, why not do this? Having some advice. Jane's making the point that some people find that once they're in the water, they're okay. I think it's different. It's different for different people, but I think that often is true. But that's about the fear avoidance, and I think of my years as a child screaming and refusing to go anywhere near the water. That if something isn't familiar, it's frightening. What would be great, wouldn't it, is if people much earlier on, when people first started to get a bit of knee pain or a bit of elbow pain or shoulder pain or whatever it is, if at that stage people's response was not what a lot of people's response is, I need to reduce the exercise I do. If people's response were, well, what I really need to do is increase my level of activity before the arthritis gets really bad. So your first response to developing joint pain is to get into the water, or it could be land-based, but we're talking about water today. And at that point, it's then it becomes something you do, and even if your arthritis gets worse, you've lost that fear and you're able to keep exercising. The difficulty often is that people come to us when they're in a bad way, and that's where you need the tier 3 and the tier 4, the higher levels of intervention. But the aim of that needs to be to get people to be self-exercisers, because otherwise they're going to struggle. So a lot of people are having physiotherapy. That point is coming through that people are making. And it's true, but are we doing enough? I did some teaching for our physiotherapists at the hospital, I say recently, I think it was about 6 months ago, and it turned out that they really weren't aware, and I'm not blaming them, but we don't have joined up systems, so they were not aware of the different physical activity interventions or facilities or provision locally. So people were coming to the end of their physio, but one thing that wasn't happening is signposting. So if you're coming to the end of your physiotherapy, as part of that, it may be some people do, but it certainly wasn't happening near where I work, is what systems are in place. Do the people doing physiotherapy know what's available locally and have the skills to have a different sort of conversation with people about what sort of exercise do you want to do after the physiotherapy? So think of physiotherapy as equipping people to be physically active in the long run, as opposed to, I sometimes see people, have you had come with say knee pain? Have you had physiotherapy? Yes. What did you learn in physiotherapy? They show me how to do some exercises. Are you still doing them? Oh yes, I do them for 2 minutes, 5 minutes every day, or 30 seconds every day. Can you what exercise do you do? And they show you an exercise, and it's a really trivial exercise. You think, well, no, you need to be moving on to the next exercise. Sitting in your chair, straightening your leg is not going to be enough. It's a great place to start, but you need to be moving on. And so we're not always, some physiotherapists will be doing this brilliantly, but we're not signposting people to the next tier to become active, but also as a system, we're not making everybody aware of what's available and where it's available, and exploring with people what they may or may not want to do. So I think that we've identified the idea of some CPD training that could be really helpful, of something along the dementia-friendly line where there's some arthritis-friendly program that could be rolled out, could be really interesting. So individual learning, or sort of a more system learning, but then also there needs to be that joined upness. And I think that goes back to the initial things, the questions that somebody asked about, who do you speak to? It has to be joined up with the local public health system. It has to be joined up with the local arthritis system, if you like, so the physiotherapist, the occupational therapist, the general practitioners, the rheumatologists, the orthopedic surgeons, so that people are are joined up and know what's available. So, even if you've had your knee replacement, you're not just getting, well, you need to exercise, you're actually getting information about what exercise options are available locally, and if you're in a locality that has health trainers, that the health trainers feel equipped to give people, to support people with arthritis to exercise. So, yeah, the individual education, but also thinking about what we can do to connect the system up. And just a point on the worries that people have about what advice to give. I think there is almost no condition I can think of where I would say you cannot and must not swim, or actually really do any form of exercise. I think if people have osteoporosis, that's fragile bones and are at risk of fractures. There are forms of exercise which we advise against, so anything with rapid movements, anything at risk of a fall, anything with a lot of rapid twisting. But I can't think of anything water-based. It's an interesting question. National Osteoporosis Society do a booklet on exercise and osteoporosis. I can't think. There's something like golf. You do not want to be twisting your spine like that, and nothing with sort of a lot of bending because you can risk breaking a bone. But I can't think of any reason why you wouldn't, anything really water-based that would mean you shouldn't do exercises if you have osteoporosis. And almost anything else, the advice I generally give people, I think this is good, safe, general advice, is it's normal the day after exercise to feel some stiffness and pain. But if it's severe, if it's really bad and it means you can't function, then you've just done too much exercise. And if your muscles aren't strong, or are tight, and you're not used to exercising, then you need to build up gradually. So if you try doing something and then the next day you're in a really bad way, it doesn't mean you've done yourself an injury, it just means you did too much too soon. And it might be that you can only do 2 minutes, or you can only do 5 minutes to start with. And then you're going to build that up. You start 1 week 2 minutes, and after a couple of weeks of doing 2 minutes, you're going to build up to 3 or 4 minutes. And doing it regularly is more important than doing 5 minutes in the pool 3 times a week is much, much better than doing an hour once a week. Doing anything once a week, you're probably going to struggle ever to gain any strength to really get an improvement. It's really the regularity is what really matters. So don't worry about pain the next day. It's not an injury, but if it's really bad, it means that you need to build up more slowly. Pain during an exercise usually does suggest that you're putting a bit too much strain on something that isn't ready for it. So you should either pull back and do whatever you're doing either less or more gently. And if you find that a particular activity, say a particular stroke, consistently causes you pain, then either when you're doing it, then either you should think about avoiding that particular stroke, or better would be to see an instructor who can look at your stroke and see if you're doing something wrong. So, common problems, people in crawl can often get impingement problems at the shoulder, which can usually be improved by looking at the strike angle, and so how you strike the water and how you pull your hand through the water, trying to avoid a lot of the twisting and zigzagging that used to be fashionable tends to cause the problems. And breaststroke can sometimes cause knee problems, but I think not to be rigid. And actually my mum, who has arthritis of the knee, does breaststroke, and if she misses a week of swimming, she'll know about it. She really finds, so I'm very much against advice that says if you have A, only do B, because I think people are not that straightforward. You've got to experiment and find out what works for you, and not be afraid of experimenting. You're not going to cause harm, not if you start gently and build up slowly. Starting gently does not mean gentle forever, but it means if your muscles aren't strong and supple and the joints aren't strong and supple, start low, little and often build up.